Forward Media. This is Healthcare Musings. I'm your host, Dr. Hashem Hasabala. Welcome to Healthcare Musings, everybody. Happy to have you with me. So I came across this. I subscribe to Sensible Medicine, which is an excellent Substack. I recommend everybody subscribe to it. It's run by Dr. Adam Sifu here at the University of Chicago, great guy, and Dr. John Mandrola, wonderful Substack, and they have guest posts. I've had a guest post on it. I was blessed to have that, and my guest today also had a very intriguing guest post, and that's why I wanted to have her on the podcast. So when I had a conversation with Scott Becker of Becker's Healthcare, he said, I'm paraphrasing, that I think we've lost the battle with primary care, that I think the majority of primary care is going to be delivered by APPs, PAs and APs, PAs and NPs in minute clinics and maybe even doctor's offices. There just aren't enough primary care physicians to meet the needs of the population. And he's lucky enough that he could afford concierge medicine. Maybe I'm blessed enough that to be able to afford. I don't, but I'm saying if it came to it, I could. I'm very blessed to be able to have the means. Most people do not have the means to spend 10, 20, 30 or more $1,000 per year to have a primary care physician be there. You can text them and everything like that, and they can see you anytime and spend 3 hours with you. That kind of primary care is kind of low. And he said, I think the battle's been lost, which I thought was very intriguing. I work with APPs. They're fantastic. I think especially the good ones, they can practice at the top of their license and they do a fantastic job. And we also need primary care physicians, right? I don't think, just like we need critical care physicians, just like we need emergency medicine physicians, even though there are APPs that work in the emergency medicine, in the emergency department and the ICU, we still need physicians. We always will. So Dr. Colleen Smith, my guest, wrote a Substack, and I'll let her talk about it in detail, that had a very interesting idea about how we can address the shortage of primary care physicians. And so when I read the Substack, I was very intrigued, and that's why I had to have her on the show. So welcome, Dr. Colleen Smith. It's Healthcare Musings. So happy to have you.
Thank you so much for having me. I'm happy to come on and talk about my article, and also just to give you a little bit about myself. I'm an emergency medicine doctor. I trained in New York City, and I'm currently practicing in New York City. I work in 2 different large hospitals here that see trauma patients. They're level 1 trauma centers, also have, very high level ICU, critical care capability, pediatrics. So I'm seeing patients all the time, and although I'm not in primary care, I'm kind of at this junction where I see a lot of patients who don't have the primary care that I wish they did have. And so, improving primary care is near and dear to my heart, because I think it will also improve the health of my own patients who I see every day and take care of in the emergency department.
Yeah, absolutely. And you know what? In the ICU, we also see the impact of the lack of primary care. Palliative care discussions, end-of-life discussions, goals of care discussions, all the time fall to us. In fact, there's another Substack I recommend everyone subscribe to, especially who is pulmonary critical care. It's called pulmccm.org. And he just talked about the guidelines that just came out about palliative care and end of life. And hospitals have to do a better job according to the guidelines. And it frequently falls to critical care specialists to have those conversations about goals of care and end of life and what you want. And saying, do you want me to do everything, is the absolute worst question you should ask a patient or their family, especially when that patient is an extremist. So I think we also see the dire effects of the lack of primary care. So, Dr. Smith, why don't you just kind of go into what you went into, and which is what I want to talk about, what you had mentioned in your Substack.
Yeah, so the article that I wrote, that I was honored to have Sensible Medicine publish with me as a guest author of, was really about how I think that we should loosen some of the restrictions and also improve the way that we educate doctors, or maybe make some changes to the ways that we educate doctors, to allow doctors who are practicing in primary care adjacent specialties, things like emergency medicine or surgery, even general surgery, or OBGYN. Many obstetricians, gynecologists are essentially the primary care doctors for the women who come through their practices. So I think if we were to create some sort of educational pathway that's different than residency for these primary care adjacent specialties, we may be able to funnel doctors who, for whatever reason, are struggling to continue in some of these other specialties but would like to continue to be doctors, funnel those doctors into primary care. Right now, it's pretty difficult to do that. A lot of the reasons why someone might go into primary care are things like if you're primarily a surgeon and you have an injury to your hand and you can't use your hands anymore. Maybe you would go into primary care. You can still use your brain. Um, if you, maybe you, something that happened to a colleague of mine is that they developed a autoimmune arthritis that made it difficult for them to work in the emergency department. There's like getting up and down, doing procedures, running around all the time. It was just physically too difficult for them to do that job. And so they could go to urgent care, maybe they could do some other things, but it was hard for them to do procedures because of their hands, but they could have gone into primary care. On the other hand, they probably couldn't have done a repeat residency just because of how grueling a residency is. And I'm not sure that having had done a residency once already, you need to repeat it, because a lot of what you learn in residency is also things like time management and how to talk to patients and how to interface with your colleagues and how hospitals work. You don't really necessarily need a new residency to learn those things if you've already done one. So my suggestion was that we could have some sort of training pathway for mid or late career doctors who have already seen patients for many years, who are in primary care adjacent specialties, to learn some of the medical knowledge pieces that are necessary to practice outpatient primary care. And it could even be individual specific. So whatever that particular person needs to do based on their career, what knowledge gaps they need to fill, we fill it. In the end, they take an exam and they get some sort of certification that's accepted by the American Board of Medical Specialties, by the AMA, that allows them to participate in the insurance place market and allows them to be covered by malpractice to practice outpatient primary care. I think it's something that there would be maybe not hundreds of thousands of doctors, but I bet there would probably be thousands, if not tens of thousands of doctors over a course of years who might be interested in doing some transition like that. And they would pay for it themselves, most likely. It's continuing medical education sort of thing. And I think it's not going to completely solve our shortage of primary care doctors, certainly, but I think it would bring doctors in, keep doctors in medicine who we're losing because of things like illness and disability, and even just wanting to take time off and be able to have a 9-to-5 job instead of a, around the clock 24/7 job. And I think it would go some way toward helping solve some of the problems that we're having with our lack of enough primary care doctors.
I mean, that's fascinating. I think, I mean, the reason why I did pulmonary critical care as opposed to just critical care is because I wanted an off-ramp out of the ICU one day, right?
Yeah.
I did, when I came out of training, I did the traditional private practice, one-stop shop. I'm everything everywhere at one time, which is not a good way to do it. I ran around like a chicken with his head cut off for multiple years, right before, and so I realized this is ridiculous, right? This is not how you're supposed to do it. And I was just, I think I was a good outpatient I think I was a really good outpatient pulmonologist. My patients, I loved them, they loved me, but I was not a very good intensivist because I couldn't stay more than 20 minutes before I have to leave the ICU and go round in the hospital and then go to the office for the day, especially on my office days. That's not what critically ill patients need.
Mhm.
And one day, I'm still not there yet. I still have 20 years of practice left that I have to work. I'm not there yet. I still love being in the ICU. And one day I know that I'm not going to like the ICU as much.
Mhm.
And I need an off ramp out of the ICU. And so pulmonary medicine is that off ramp. That's why I'm continuing to
Right.
keep my sleep boards and my pulmonary boards active. And I have my inpatient medicine boards. So I don't think I'm going to become an internist. And still, you're right. That's why I counsel everyone. If you want to do critical care, you do a pulm crit because that'll be your way out. And so I think this is a fantastic way for somebody who's just done being in the emergency department, but not done being a doctor. Intensivists, when they're done being intensivists, they're done, right? A lot of
Yeah.
emergency medicine physicians do other things, and that's great for them. I've talked to them, and I've had people on the show, like Dr. Jeff Willis, who now does expert witness work full time. He was an emergency medicine physician. My uncle and his son, my cousin, they're both emergency medicine physician. My uncle is a family medicine doctor who did emergency medicine, so he's still doing it. He's God bless him. His son is beginning to feel the effects of the job, right?
Yeah.
And this is a fantastic way to continue to serve, right?
Yeah, I mean, personally, I've gone to part-time. It's just a very difficult job. I love the job. I love the work. I love seeing patients. I love doing critical care. It's just fascinating. I love working with residents, but it is a physically grueling and mentally taxing job. And you were saying that you had a period of time where you were working in the clinic and in the ICU, and it is just very difficult to balance that type of work physically and mentally for a long period of time. And then if you add in things like the circadian rhythms that everyone get thrown off, because in the ICU you have to be there 24 hours a day sometimes, and in the emergency department there's got to be a doctor there 24/7. You really do start to you know, I don't know. Everyone has a different sort of life expectancy, I guess, for their career, but 10 years, 15 years, 25 years, it starts to wear on you. And there's even data showing that women in medicine, especially in some of these high intensity specialties, have trouble conceiving compared to the population.
Really,
And
really,
we don't, it's not entirely clear why, but there's some theory that may be due to imbalances in cortisol levels because of stress and problems with circadian rhythm and things like that. So, I think we are really hard on ourselves as doctors, and we hold ourselves to a really high standard, as we should. But that is partly why I think having making it so that there's an off ramp into primary care, which we desperately need doctors for, in a way that is safe. So there's some sort of a accepted educational component to it, so we know that everyone has the knowledge that they need. And I'm not saying, I think some of the comments I got, I think people thought I was saying, oh, anyone can just do primary care. But I don't, I want to be really clear. That's not what I'm saying at all. I think this would be something for someone who has already done a residency, someone who's already worked in a specialty and knows what it means to take care of patients. And so it may mean that someone who, like, if a pathologist wanted to do this, for example, not dissing on pathologists, they're amazing, great doctors, and we use them all the time, and they're super helpful for us. But maybe
right.
they would need to do a residency because they really haven't spent a lot of time doing patient care.
Mm-hmm.
um,
No, that makes sense. Now, okay, so let me play devil's advocate here, or
yeah.
so what if I have a general surgeon that does general surgery, right? How is that and then that general surgeon becomes a primary care physician? Why is that general surgeon better, and I'm being provocative on purpose, better than a nurse practitioner in a primary care physician's office, or a nurse practitioner in a minute clinic?
So there are cases where, and maybe this is a little nuanced, they might not be. I think some, as you said, some nurse practitioners and physician assistants who, especially those who have been practicing for a long time in one particular specialty, sometimes they really are phenomenal at that job. And certainly I have PAs who I work with in the emergency department who I've learned things from. On the other hand, I think that there's something about medical training for doctors that includes this sense of responsibility toward your patients and a sense of, I guess, it's actually kind of hard to put into words, right? But I think there's sort of a sense of responsibility that doctors have towards their patients. There
Hmm.
is some additional, um, even internal medicine residencies are difficult and push doctors and work nights. There's some sense of you know what it means to be pushed to the edge of your ability to function
Hmm.
and still be able to function at that level. There's a sense of decision making and training in how to make decisions that you get as a doctor, and particularly during residency, that I think a lot of PAs and NPs don't really get in their training. There's some team leadership and followership skills that you learn that are different. And so I do think ultimately that kind of responsibility and the responsibility for making difficult decisions and sticking with them does differentiate the training that doctors have from the training that PAs and NPs have.
No, I think you're right. There again, I don't want to. Our group, our practice is very heavily invested in advanced practice providers.
Mm-hmm.
APPs, CRNAs, PAs, NPs. I work with them. I lead them. They're fantastic. They're wonderful. And I have had them on my show. I've had them on the podcast. Especially. So I
Yeah.
don't want people to think that I'm against them. And the training is different. It really is. It's a longer path to become a physician. I think medicine is still a guild. There's still an
Mm-hmm.
apprentice. You have to work with as an apprentice under a
Yes.
mentor and a teacher. It's just different training. And it's a longer path and it's a harder path. And
Mm-hmm.
and and I don't disagree. And a lot of people still, I think there's still something special about having a doctor be your primary care physician, and something special about being a doctor. It's just different, right? Um,
Yeah.
we see it all the time in the ICU. The way the ICU nurses, and I'm a huge advocate and fan of ICU nurses. I think they're one of the best in the hospital, and their training and the way they approach the case is different than me as a physician.
Mm-hmm. Mm-hmm.
We can't not, there's not, it's just
Yeah.
different, right?
It's almost hard to say specifically what it is. And maybe if it weren't a podcast and I had more time to really sit and think and try to write about it, maybe I will try to write about it so I can
Yeah,
really wrap my mind around what the differences are, because I that's part of what I like about writing, is it forces me to concretize these things. But you're right, there's something different about the way that PAs and NPs approach patients that's different from doctors, that's different from nurses. And I also agree with you. I work with phenomenal PAs and NPs. I work with phenomenal emergency medicine nurses. They have helped me save patients. They've caught my mistakes. We work
yep,
as such great teams. I would not give them up for the world, but there's really just some different way of thinking that is part of the training for each of these specialties. And
right.
I think that's why it matters that we continue to have doctors in primary care.
Yeah, I don't disagree. I don't want people to come away thinking that we're disparaging APPs. We're not. I'm not at
Yeah.
all. I never have. I never
Never.
have. And I work alongside
Mhm.
PAs and PAs and NPs in the ICU, and they're phenomenal. And they I trust them, and I don't lose sleep. And as a telecritical care doctor, I I back them up, right? But they're on the ground. They're seeing the patients. They're doing the lines. They're doing everything. I don't worry at all. I'm not worried that
Yeah.
they're going to do something wrong. Um, and still I wanted to become a doctor because I wanted to have that kind of relationship as a physician. It's just different than being. There weren't many when I was in training, and now I'm getting old now. Um, but it's just different, right? Um, and I think there should be it's a tragedy when I see excuse me, emergency medicine physicians leaving the field. I get
Yeah.
it. It's really hard. It's really hard. The ICU
Yeah.
is really hard.
Yeah.
I did one shift as a resident in the ER, and I said, "This is for the birds. No way am I doing this." Literally one shift, right?
Yeah,
One
that's
because
pretty funny.
we could moonlight as an ER doc. So I did it one day, and I said,
Yeah.
"No freaking way am I doing this for the rest of my life." So hats off to you guys. I like to give my uncle and cousin a little bit of difficult time
Hmm.
because some of the stuff that comes to the ICU from the ER, and I'm planning to have one of my colleagues who's an emergency medicine and critical care doc
Yeah.
on the podcast to kind of rib him a little bit and go back and forth. But
Yeah.
um, there's just it's a tragedy when we lose a physician. It really, I
I think
mean,
that's, yeah, I agree. I agree. And especially when it's over something like whatever specialty they picked, they cannot do it for some reason that has nothing to do with their ability to think as a doctor or interact with patients. And yeah, I think we should have some off ramp for them. And
yeah,
especially with primary care being in the kind of dire straits that it's in. I mean, it was shocking to me to read. One of the statistics I put in the paper was that even though more people have health insurance than ever before, fewer people than ever before have primary care doctors. So,
yeah.
health
Wow.
insurance is supposed to give you access to care, and it actually isn't, because it's not helping you get a primary care doctor because there just aren't enough of them.
Yeah,
It's
there aren't
just,
enough of them, and the job has become so hard, so hard.
yeah, yeah.
I don't begrudge my PCP that it takes some days to get back to me. It's so hard.
Yeah, and I think those are like, so, a lot of, one of the other critiques of my essay, which is not wrong, is that this is not going to fix primary care. And it's certainly not. There are so many other aspects of primary care. They're underpaid,
Hmm.
overworked, expected to see patients in such a small amount of time. And and you were mentioning how like palliative care, how much palliative care you're doing. I mean, how much better would it be if primary care doctors actually had time to have those conversations with their patients? The doctors who know their patients because they've been following them for years, who've seen what they do, who know what's important to them, what the patient wants out of life. And instead, it's the ED doctor or the ICU doctor who's never met them before, ever, who's having to have a conversation with them about what they want out of the end of their life, what their goals are, how they would like to live or die. It's just it's just unbelievable to me that we haven't figured out a way to make that better for our patients.
Yeah, you're 100% right, and we have to, right? There's no question. Otherwise,
Yeah,
and it's sad, and again, I don't begrudge them. It's sad that they don't
yeah,
have the time. They don't have the time.
yeah.
And there has to be a way to make and whether it's with AI tools and scribes and things to make the
Mm-hmm.
the bookkeeping, the tediousness of the job better, so to give them more time to be right? To be physicians,
Mm-hmm.
right?
Yeah. Yeah, I am hopeful that AI tools will help. I also think something like this proposal I have that just frees up the educational landscape a little bit. You
Hmm.
know,
Right.
um, it certainly not saying doctors don't need residencies, but just saying let's free up the educational landscape a little bit.
Yeah. No,
Um,
oh,
mhm.
100%. I mean, I haven't done outpatient pulmonary in a while, and I'm still keeping up with it with my longitudinal assessment, my
Mhm.
LKA with the ABIM, so that I can hit the ground running, working working in a pulmonary office
Yeah.
where it's not going to be completely foreign to me. Maybe the drugs have changed, but reading up on guidelines and learning and being tested, it's not hard to do, right?
Yeah. Right.
I mean, the skill is
Right.
there. And I like what you said about residency. We've gone through and learned. the skills we need to, because residency really is every patient's a teacher, even now.
Yeah.
I'm 20 plus years out in practice. Every patient is a teacher. Every case teaches me something new. So residency gave you that, and I think there should be a way to do it. I would much rather have that than bring in another physician and not have them do residency, right? And just because the shortage is so dire that we're just, if you just, shadow for a few years, we'll give you a license and you can practice. I'm sure they're great physicians where they come from. I'm sure wherever they're coming from, I'm sure they're amazing physicians. It's still different to work here, right? I'd much rather give the people who've worked here understand how it is to practice in the United States, to be able to continue to practice. You know what I mean? To continue to practice. And I don't want to. I'm not trying to despair. I have a lot of foreign colleagues, and I will again work with physicians who have done residency here. And they're foreign medical grads, and they're fantastic. But they did residency here, right? I don't know how. I mean, I was very dangerous as a intern.
Yeah, so was I. I mean, so is every doctor. I haven't met an intern who isn't dangerous yet.
Yeah, I mean, and the worst thing about it was because I didn't know what I didn't know. I thought I knew. I'm like, I got this. I graduated top of my class. How hard could this be? Oh, it's very difficult.
Yeah, and I think residency teaches you also how to know what you don't know and how to learn. As you said, that every patient is a teacher, that this is a life of learning. This profession is a life of learning, and I think you're right to an extent. When we're bringing people from other countries where we don't know what their training really entailed, where they haven't had the experience of working with supervision in our system,
right?
I think we're taking a little bit more of a risk than we would be taking a doctor who has trained and worked here, done residency here, worked here, and then just cross-training them a little bit in some of the medical knowledge that they're missing. Someone asked me, like, do you think that someone could do the same thing for emergency medicine? And I think, yeah, they probably could. If you went from internal medicine to emergency medicine, you would need to learn some critical care skills. You would need to learn a few procedures, and you'd probably need to do a brief period of supervised shifts in the emergency department, just because the way that things work in the emergency department is kind of weird and different. And But I don't think you would need to do an entire residency again, assuming you have been taking care of patients for many, many years. I just don't think you would. I think the difference is we don't need emergency medicine doctors. We need primary care doctors.
Precisely. No, that makes total sense. Well, I mean, we'll see where that goes. I wanted to kind of amplify this message, and kind of, I think our system is such where we need out of the box thinking, and we need to figure it out, and to figure out because it's only going to get worse. And nothing against APPs. Again, I don't want people to think I'm against APPs and foreign medical grads. I'm not. Yeah. At the same time, we have Dr. and Scott Becker had a good point that we keep being compared to Sweden and Norway and Denmark, but we are 350 million people. Those countries are, the population of Denmark, I don't know what it is off of my head, but it's much smaller. It's much easier to provide healthcare for that small of a population than the United States, where there's 350 million people.
And our population is much more diverse. It really is. It's just much more of a diverse country, even in terms of not just speaking in terms of like racially diverse, but diverse in terms of cultures and kind of worldview. We've always been a country of immigrants, and our population reflects that.
Yeah. 100%. So the challenge of providing healthcare for everyone here is way different. And he made a great point. We can't compare it to a small Scandinavian country and just say, well, let's just do that. It's different.
I agree.
It's much more.
Yeah.
It's much more complicated, and it's only going to get worse, and we have to kind of figure out how to do it. I recommend everyone to sign up for Dr. Smith's Substack. What's it called, Dr. Smith?
It's Dr. Colleen Smith, so with no spaces. So pretty
Perfect.
easy.
And I mean, her latest Substack was awesome about health savings accounts, and I agree completely.
Yep.
I think we should be more liberal in the things that we can use it for. I don't know that $1,500 a month is going to pay for insurance for a family. It won't for my family. It won't.
Yeah, it won't for mine either. I mean, it will take the edge off, certainly, but it won't pay for my family for sure. But I do think, which is also why, though, I think we should be expanding. This is a different topic, but we should expand health savings accounts in such a way that just anyone can create them, because everyone should be encouraged to save for their health.
100%.
Health is such a vital aspect of your life.
Yep. I agree.
Yeah. So if you want to read more, check out my Substack.
Read more. I mean, this could be a whole other. Maybe we'll have you come back talk about that.
Yeah.
But this is fantastic, Dr. Smith. Thank you so much for your time.
Yeah.
It's a fantastic idea. Let's see where this goes, and if I can help amplify the message, and maybe we go to. I don't know where to go from here, but at least let's begin the conversation. Dr. Smith, so happy to have you. Thanks for being.
Thank you so much for having me. So nice to meet you, and great to chat. Happy to do it again. Yeah.
Oh, thank you so much. We'll see you soon. Take care.
Great.
Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.